Thank you, Kensington, for supporting these powerful educational events for our aging community. My father lived at Kensington for 7.5 years, and Kensington is near and dear to my heart. They took care of him through his challenge with Alzheimer's disease. Kensington focuses on relationship-based care, care built on the foundation of their promise to love and care for your family as they do their own. It is programs such as the one you are attending now that are so important for those of us walking through a caregiver journey to hear from these incredible expert professionals. Kensington is truly privileged to support care partners and professionals from coast to coast. Please utilize the Q&A function to submit questions during the webinar. We are hopeful that today will be a conversation with you for the audience. Caregiving is personal, and we all have unique challenges. This is an opportunity to ask our team of experts. Additionally, a copy of today's webinar will be delivered to your inbox in the next few days to share with friends and family. And of course, watch again. Please join me in welcoming Monica, Tammy, and Lisa. And thank you again for joining us today.
Thank you for having us.
A special acknowledgement to Monica Moore. Today, she is celebrating her 10-year anniversary of heading up all the support groups and incredible resources at UCLA. Congratulations.
Thank you, Susan. Greatly appreciate that. Thank you.
You must have been 12 when you started.
I was. Unbelievable.
Anyway, let's go ahead and get going. Once again, I just want to. Hello.
Oh,
Hi.
Dr. Adrissi just joined us as well. So she's we have Dr. Adrissi listed as Susan Evans. We will change.
Yeah, I'm
Yes,
changing
Dr.
that right
Adrissi, thanks for
now.
being here.
Although I can do that.
There you
But
go.
I can't do your presentation or answer your questions, but we can switch for the day. But let's go ahead and get started. And I think what we're going to do is kind of lay a framework here so that's kind of an umbrella so we understand how the discussion's going to go. We're going to start with some questions and kind of laying it out for the caregiver aspect of it. And then our special guest, Dr. Adrissi, is going to talk more about the clinical approaches to different types of dementia, specifically LBD and Parkinson's, which is going to be great. So, Monica, I'm going to ask you to kick it off. And once again, this is a roundtable conversation. So chime in when you want. And please, audience, utilize the Q&A function.
Absolutely. Yes. Thank you, Susan. And again, thank you everybody for being here today. A special thank you to Dr. Adrissi, who I will do more of her official formal introduction in a moment. But, first thing that we wanted to talk about is just there is this world of what is dementia and what are, and sort of trying to level set it a little bit here. Apologies, my computer's running just a little slow as I'm trying to get this up and going. So we want to just talk about the world of what is dementia. So dementia itself is a word that describes a group of symptoms. It is a word, oh, goodness gracious, my computer, sorry, everybody. It is a word that, we look at these two different parts of based upon cognitive decline as well as a functional impairment. And the two pieces need to be working together and side by side. We all have basic, continue to share. Okay, we all have, our own basic cognition and the way that we all think. But really, when is this word of dementia actually come into place? So dementia itself, we have cognitive decline. These are your basic areas of cognition: thinking, language, memory, judgment, reasoning. And we all have strengths and weaknesses in these areas. But dementia kicks in when there's an actual functional impairment with those areas of cognition. So let's say the functional impairment is taking medication. You're having a problem with your judgment that is now impacting your ability to take medication properly. You are having a problem with your reasoning, which is now impacting your ability to drive safely. So it's really this combination of the two. It is important to realize that this is not a normal part of aging. And so again, this word dementia is a word that describes symptoms, and there's lots of different diseases that can cause dementia type symptoms. Obviously, in these next two sessions, we're going to be talking a lot about this. This is, the basic umbrella that we talk about. And then underneath is just a sampling of some of the different types of dementias that exist. Frontal temporal dementia, Obviously, Alzheimer's disease, stroke, vascular, Parkinson's disease, Creutzfeldt-Jakob, Lewy body, traumatic brain injury, et cetera, et cetera. This could ultimately be like a multi-week symposium talking about all the different types of dementias. But for the purposes of our presentations today and in 2 weeks, we're just limiting these to talk about just some specific types of dementias. But I always like to make sure we show this image where people realize it's dementia is the overarching word, and these are different types of dementias. It's not that one comes, it's not the chicken or the egg, what comes first. It is symptoms, and then what is causing the symptoms. And then this image here, it's really hard to find a true breakdown of the different types of dementias. Part of this, I think some of the things that Dr. Adrissi may be speaking about today is about diagnosis, is about, how many doctors are actually doing thorough diagnosis to figure out, do you have vascular? Do you have a mixed dementia? Do you have FTD? Do you have Lewy body, which isn't even mentioned in this pie chart? But again, it's sort of hard to find any true and fast, hard chart that shows the percentages of dementias. But Alzheimer's is going to be your most common form, followed by vascular, mixed dementia, FTD, Lewy body. These sort of go back and forth between which one is the percentages itself. So, we talk a lot about why. Why should we diagnose? What does it matter? And these are really some of the things we're going to be focusing in on these presentations that we're going to be having here.
I actually have a question for Dr.
Yeah.
Adrissi. Do you think, from a clinical perspective, that 10 years down the road, there may be new dementias that are discovered?
Yeah, I mean, I think things are always changing, right? I think one of the great examples of that is COVID-19, right? We had a lot of the, people having sort of this brain fog, a slowness that wasn't actually resolved shortly after the infection and the infectious phase. So there's a lot of conversation going on right now about inflammatory diseases, whether it's infectious, whether it's autoimmune, and what that does to the brain long term. So yes, I think as we are, having more infections coming on, getting a better understanding of autoimmunity, and so a lot of autoimmune disorders for those on the call is when your immune system, instead of attacking, things on the outside like infections and bacteria, it actually starts to attack your own body and different organs in your body. And so that's another cause of inflammation. So I think there's going to continue to be different types and names of it. I think even within the names that we use right now, I think we're going to start getting more specific, right? Even within Alzheimer's disease, within Lewy body, we're starting to find out different genes or flavors, if you will, of the disease. And so I think our understanding and the real specificity and the detail of our understanding of dementia is going to change significantly over the next decade or two.
I really wish my father passed away from Alzheimer's, and now my mother is really challenged with Parkinson's. And I just wish, brain disease is so hard. I'll never forget when my dad was diagnosed and I said, okay, what's plan A, plan B, plan C? And and that was 10 years ago. And now I'm so grateful that there would be a bit bigger conversation going on. But I just, it's so complicated because the brain is just wired so differently for everybody. So thank you for doing what you do. I really mean that because, now we have these great neurologists and these people that are studying the brain and studying how, and what you just said, COVID-19 is a perfect example. No one knew, that I was going to have long COVID and now have semi-permanent brain fog. So
We're
thank you.
still learning. And this is the humility part of being in the field and being in medicine is that things change, our understanding of things, what we think we know, we don't know entirely. So if you come across a doctor who says that they know everything or most of the things in their field, that is a red flag. Because the more you know, you realize the more that we don't know and the more that we're still finding out. So exciting time, but then also it's sort of like a time for our curiosity and to run well.
And, I know you're challenged with educating all the primary care physicians so that they can somehow screen all their patients and figure out, what's the best, because it's so complicated, you really need a specialist.
Mhm.
So it's
Yeah.
really a teamwork between team.
Exactly. And I think that's going to be a growing conversation. I think you've probably had some it's out of the scope of this presentation, but some of the newer sort of disease modifying medications that are just starting out in Alzheimer's disease and dementias. And it's actually for that very early piece, right? That mild cognitive impairment right before you get to dementia. And so what does our screening look like when, they're actually still independent, but this is actually that small window where we can actually start to do something about it, whether it's through clinical trials or through treatment to change the trajectory before we start losing too many of those brain cells. And unfortunately, we can help sort of the connections and the synapses between brain cells, but it is almost impossible to kind of create new ones. So growing conversation and really where public health meets neurology and medicine.
Mhm.
Oh, I
And
love that.
one of the
And
things that we were talking about when we were sort of doing some of the pre-discussions for this seminar too is to really see, why is it that it's important that we push for proper diagnosis? Why is it that we push for, not just allowing the word dementia to be somebody's diagnosis? And Tammy, did you want to sort of talk on some of those topics that you've seen, like working with your clients?
Yeah. So what I see a lot in my private practice is we really have to educate that all behavior have dementia, but we can see impairment in the speaking. We can see impairment in their ability to process. It's not just memory loss. And the other thing that's important is behaviors tell us a lot, where they are in the progression, but more importantly, especially early on, telling the physician what the behaviors are that you're noticing is going to be significant in helping to diagnose it as well, right? Different dementias present differently initially. With Alzheimer's, initially it's going to be short-term memory loss. That's sort of what it is. But with Lewy body, we may have some motor skills or executive functioning or hallucinations occur pretty early with Lewy body. Vascular dementia, we're going to see slower processing, slower thinking. And then with frontal temporal, initially, it may present as difficulty with language, personality, abrupt personality changes. So, what I encourage people to do is when you start to even notice something is off, we start documenting what we're observing. And there's several reasons why I enjoy having people document because it provides a lot of clarity. Number one, the caregiver starts doubting themselves. Well, maybe it's not happening as frequently, or maybe my loved one had a moment of lucidity and maybe they're not, maybe they don't have what I'm thinking that is, off. So document whenever you think something's off because sometimes those behaviors can be driven by something else medically that's going on that might be treatable. And then we can go ahead and treat that and maybe the symptoms go away. The second thing I like about documenting is doctors like detail, they like data. And now it's not hearsay or when or if, it is data. And we have dates, we have behaviors, we have specific facts to work with that can also shed some light on to what's happening and where might we be in the progression, right? We know dementia progresses. So we document the behaviors. So, It allows the caregivers to get a sense as to what direction this is going to go in. It helps to educate us to have a better understanding so we're more realistic in our expectations. And I think that's what tripped people up a lot, is that the more I understand what to expect, the better prepared I'll be. So I'm a big fan of documenting any type of behavior changes, because also you have side effects of medication. Did this behavior change because of? And I just think it provides us with so much beneficial information. Yeah. Okay.
Jennifer, Dr. Andrisi, I just want to call you Jennifer.
That's fine.
Excuse me. One of the things that to drill down a little bit farther into the symptoms where we're talking about Lewy body dementia and Parkinson's and vascular. As a family caregiver, what would a family caregiver look for in the subtle first signs of those three distinct dementias that differ from others?
No, that's a great, great question. I have a presentation, like a very short one. I don't know if it's a good time to show you now just for visuals, or we can also just talk through this. I can start by talking through it and then we'll can get into the details later. But you and Monica really set the stage for the conversation with the umbrella, right? The umbrella of dementia. And usually that's sometimes where the conversation stops for people,
Mhm.
and it's hard even to look back when you're in the doctor's office and someone asks you about family history. And you're just like, oh yeah, grandpa had dementia. Like, oh, what was it from? I don't know. It was just dementia, but now we're starting to have more language and details around that. As far as the diagnoses and the different categories, a lot of it has to do with timing and timeline. So Tammy, you're spot on with sort of the details and the importance of details. One of it's almost like a continuum or a spectrum. Parkinson's disease with dementia and Lewy body dementia is also called dementia with Lewy body. So you might hear those terms used interchangeably. And it really is a timing issue because what's going on in the brain and what's causing the sort of the breakdown of the brain cells in the dementia is actually similar between Parkinson's disease and Lewy body, right? And so alpha-synuclein is basically a bad protein, a protein that you don't want to build up in the brain, but it does in some people. And when that alpha-synuclein congregates and gets together, when you look under the microscope, if someone actually like looked at the brain, you will see these things called Lewy bodies, right? So we have Lewy bodies in Parkinson's disease, but you also have Lewy bodies in Lewy body dementia, right? And so it's like, well, who gets what, right? And then it's an overlap. So there are some people or most people with Parkinson's disease will eventually have some type of cognitive symptoms, and it's a spectrum. Some people have a little bit of the mild cognitive impairment, but it can vary to, pretty significant dementia with hallucinations. And then you have the Lewy body dementia category, where you can still have sort of the physical symptoms of Parkinson's disease, which is the stiffness, the slowness, which we call bradykinesia, sort of that shuffled walking, just taking slower to do things. Some people have a tremor, but not everybody, right? So that can get a little bit confusing for people. And it's really a resting tremor when people's hands are just relaxing. Watching TV, you'll kind of see the hand going. Sometimes you'll have a tremor in the leg or in the chin. And so you have that for people who have Parkinson's disease. And then you have that for some people who have Lewy body. So what's the difference? The difference is timing. And so for people with Parkinson's disease, the initial symptoms and the initial issues are really movement type of issues, right? They're feeling really tight on one side more than the other. They're feeling slow. They're having a shuffled, really not picking up their foot. Their foot might actually get caught on the pavement, causing some falls. They can have the tremor, etc. And then later on, they might start noticing, oh, memory's not quite there, or I'm starting to have hallucinations, but that's later on. So specifically for Lewy body dementia, for the definition of Lewy body dementia, It's defined as sort of a fluctuating cognition, which means that you'll hear like, sometimes they're actually pretty clear, pretty lucid. And then sometimes it's like, where am I? What's going on? Pretty confused. And you'll see sort of that ups and downs, which is just frustrating for the person going through it, but then also their loved ones, because they see these periods of like, oh, looks like everything's okay. So you have that fluctuating. You have the dementia, which Monica did a great job of really defining. And so that actually either happens first, that's the first thing or the first symptom that you notice, or it's noticed within the first year of the motor and movement symptoms. Okay. And so if the cognitive symptoms or the significant symptoms are, a year or further from the movement symptoms, the slowness, the stiffness, then you're talking more of this Parkinson's disease with dementia. If it's earlier and more significant, the cognitive piece, then you're talking more so about the dementia with Lewy bodies, also called Lewy body dementia. As you can imagine, since what's going on in the brain is very similar between these two groups, as we're doing research about, while there may be more research studies in Parkinson's disease, as we learn more about Parkinson's, it actually is also very helpful for Lewy body, because some of these therapies may be helpful in both. So that's the main thing. Hallucinations is something that is more common in Lewy body dementia compared to some of the other dementias. And I always kind of describe it as it's not usually, when I say hallucinations for people with Parkinson's disease with dementia, and for Lewy body, when I'm like screening for it, people kind of like, oh no, is that what I should expect? Is it going to be scary? And usually the hallucinations in both of those, including Lewy body dementia, it's not necessarily scary, right? It starts off, the first thing that people might actually notice is a sensation of passage. And what does that mean? That means that they're kind of going about their business and it just seems like something passed them on the side. They look over and it's not there, right? And that's starting to happen a little bit more regularly. A few months later, or sometimes a year or so later, they'll start noticing, okay, there's a pile of clothes over there by the window. Wait, that looks like a person. You kind of look over there and you're like, oh no, that's not a person. That's just some clothes. And so it continues to change. I think seeing people or like animals is something that's a little bit more common. Types of hallucination would be people can have different ones. So yeah, that's a bird's eye view. And everyone looks a bit different. The paces and the courses of how quickly things progress does change from person to person. But in Lewy body dementia, compared to someone with Parkinson's disease who eventually gets dementia, the Lewy body does tend to go a bit quicker as far as the worsening of the cognitive or thinking symptoms. I hope that was helpful.
Very helpful. My mother started, she would call me in the morning. She said, "Oh, your father slept with me last night." And he was just in the bed next to me. And then she'd call in the morning. She goes, "Where did he go?" Well, he had passed away 4 years previous. And so it started with that. And now we're into mice on the ground. Oh, look at the mice. Watch out. Don't step on them, but not fearful. Just, oh, don't step on the
It's
mice.
just kind of there. And initially it's some people are like, well, they don't bother me, right? And so there are some people who are living with Lewy body or even the Parkinson's disease with dementia who are like, I mean, it's not bothering me. Why? I mean, it might alarm their loved ones more than it does them. But the issue with it is that it can increase confusion. It can increase your risk of confusion. It can increase your risk of just being disoriented. And so ideally, we do try to decrease the hallucinations, whether it's by just kind of behavioral things and kind of conservative management. So making sure lights are on during the day, nice and bright. We know our days at night, everything kind of being darker and keeping the day and night kind of separate. That helps a little bit, right? People tend to have more hallucinations at night anyway. But then there are also medications that we'll sometimes use. A lot of them, the initial ones are borrowed from our Alzheimer's disease colleagues. Um, and then there is a specific medication that's FDA approved for hallucinations and delirium inside of Parkinson's disease, which is called Nuplazid. Um, Technically, it's only FDA approved for Parkinson's disease with dementia, but kind of on the times where the timing is kind of iffy or so. Sometimes we'll use it in people who are at that boundary time limit of the Lewy body dementia and Parkinson's disease with dementia.
Dr. Adrissi, you mentioned, and I don't know if you want to use it or not, that you did have some slides. I know sometimes like some visual learners, I know sometimes it's like getting some slides and some images. I don't know if that's something that you'd want to pull up to be able to share, or if you've already discussed lots of the pieces of it already. I know we're sort of
I can share some on there. I just whatever the good timing. I know that it's nice to kind of have this we call like fireside chat type of a thing. But I can
We're
also
free flowing, and I encourage you to share, because this webinar will be shared with our audience, who will share it with their friends and family. And I
Gotcha.
think having those visuals like Monica provided was great. But before we get to that, Joe asked a question 15 minutes ago. So I want to get to Joe's question, and I would love for all of us to talk about it, because I have my own thoughts on it. And that is there a blood test for the different types of dementia? And what are your thoughts on that? And I think starting with Dr. Adrissi is good, but I'd like everybody's thoughts on that. Would you want to go get a blood test if you were having some memory problems? But is there a blood test? Do you want to start,
Dr. Adrissi?
Do you want me to go
We'll
first?
have you start.
Sorry. I didn't want to monopolize the
I'll kick it
conversation.
back after you.
I wish there was, Susan. That would make things a lot more kind of straightforward. It'll also help a lot with sort of screening. But there's not. There's not a sort of a blood test, sort of like for diabetes, for instance, you have the hemoglobin A1C that your primary care doctor might check, once a year, twice a year or so. But there's not the equivalent yet. So a blood test is something that we call like a biomarker, right? So that's something that is kind of objective, if you will. So biomarkers can be blood tests, biomarkers can be imaging studies. What we do have that helps us sometimes. So Lewy body as well as Parkinson's disease, they're both clinical diagnoses. And so what does that mean? It means that it's a combination of the history, so the sort of the background that's provided from the person with the symptoms, as well as their family members, time course, etc., looking for kind of pertinent positives and negatives, and then the neurological examination. And so within the neurological examination, when people are having cognitive or thinking issues, we'll sometimes do different cognitive screens. There's different versions of it. One of the common ones that you might hear is called the MoCA. And there's, depending on the different types of dementia, different types of thinking, or there's different cognitive domains, right? There's sort of your memory or recall, remembering the words that someone said like 5 minutes ago or so, or remembering a conversation from earlier in the day. And then there's problem solving, right? There's visual spatial, where things are in space. That is actually really affected in Parkinson's disease as well as Lewy body with dementia. So visual spatial, I'll ask a lot about that, especially with driving, because you have to know where you are in relation to other people, your reaction time, etc. And so as far as tests that we can do, so there are blood tests for certain genes for different dementias, so different like genetic mutations that will make somebody more likely than someone else. However, we don't have anything that's like you take the blood test, yes, no. It's part of the overall picture. And so for Alzheimer's disease, for example, people might hear of the ApoE mutation or the ApoE sequence gene, et cetera. And it helps like how much more likely you are compared to the general population to have it. And so it's just part of the puzzle, right? We have lots of genes, probably hundreds of genes that kind of work together for good and for bad to really determine our possibility of getting different types of dementias. And then there's also our environment, right? So there's what we call epigenetics as well, sort of just like all the other stuff, right? education level, exercise, diet, smoking or not smoking, other kind of vascular risk factors like high blood pressure, diabetes. I see someone put in there about CAT scan as well. So imaging studies aren't always necessary, but are often done, right? So blood studies, you can do some of the genetic studies to kind of stratify your risk, although it's not necessary, but in some people, especially with a strong family history, you might do it. We also always check for reversible and treatable things, right? So sometimes it's like, let's check your vitamin B12, right? So that's one that I check really often because we have a lot of vegans, vegetarians, et cetera, in California. And when you're decreasing your meat specifically and some other things, your vitamin B12 can be low, as well as other B vitamins. And sometimes it's a simple supplementation, right? Or their thyroid level, make sure that the thyroid is okay. Yes, for imaging, sometimes we'll do an MRI of the brain if it's indicated. And what are we looking for there? So sometimes we're looking for different areas of atrophy or areas of the brain that have shrunk or cells have died. We also look for signs of like vascular dementia. So vascular dementia, essentially, there's, blood vessels that feed our brain, right? When there's plaque on the inside of it from cholesterol, from high blood pressure, et cetera, it can make it hard for that blood to get to the different areas of our brain, the different oxygen to get to different areas of our brain. And it causes spots on the brain that can increase that risk. And so we can see those spots on an MRI. And then there's what we call the PET scan. So a PET scan of the brain looks at really the activity and metabolism of different areas of the brain. And so the PET scan is sometimes done specifically when people are having thinking or cognitive symptoms because we're looking at different patterns. So there's certain patterns on a PET scan that look more Alzheimer's-like. There's certain patterns on the PET scan where certain areas aren't having as increased activity that are more likely in Lewy body dementia. And so that's something else that we use as part of the overall whole picture.
Good. Dr.
It's
Andrew,
amazing, Lisa, since your husband was diagnosed with early onset,
yeah.
how all of these these resources have just
Oh,
changed so much.
right. In 2005, my husband at 55 started showing really subtle signs of Alzheimer's, and it took 7 years to get a diagnosis because he was still very independent. And down the line, he was also diagnosed with frontal temporal as well. And it was a 15-year journey. So I'm fascinated by what you said earlier about inflammation in the body. And that just seems to be it's tied to everything. Um, Me as a recovering caregiver after he passed 5 years ago, I had a lot of inflammation in my body that I've been working with. Can you talk a little bit about that and how it affects everyone and how it will affect and increase our chances of having cognitive decline?
Yeah, that's a great question and a very much growing area of research. One that I will say that I am not an expert in to tell you the most up-to-date studies there. But yeah, I mean, those questions are happening across the board, like not just in neurology and dementia and sort of neurological things, but just like our body and how we're responding to things. There's some studies looking at how being raised in different areas of the city, how poverty actually affects your body, your overall inflammation, et cetera. So I'm not sure. So a lot of it is due to sort of yes, reactive oxygen, like a lot of inflammation types of things in the body that they can see on a research type of level when they're looking at either humans or animal studies. There's not usually a good clinical marker. So some people ask me that, like, can you, tell me like how's my body inflammation doing? There's some inflammatory labs, but they're not used for that. And so they would be usually normal. And so we really, in research and sort of the next steps is trying to figure out how to measure that, and more importantly, how do we target that um, as a way to just, decrease the overall probability that someone gets dementia, and then decrease the pace at which the decline happens. But yeah, I'm very interested in the area, but definitely not an expert.
Well, it sounds like it's it's an up and coming
Mhm.
expansion. Did you see? I would imagine we saw an explosion of inflammation during COVID, correct?
Exactly. Yeah.
Yeah.
And so before I was at UCLA, I was at Northwestern. And we actually had within the Department of Neurology, a COVID, basically post-COVID, long COVID clinic that was within neurology that they're following people over time, to just see, are these people more likely to eventually get a neurodegenerative disorder, like Alzheimer's or Lewy body? How do things change over time? How does that, if they do get dementia, does that look different than your run-of-the-mill sort of Alzheimer's disease? And what does that tell us about inflammation? So I think the studies are, there's multiple types of studies, or you have your gene-based studies where we're getting really specific, like what is your specific type of Alzheimer's? What is the main gene that might have increased your risk? And then there's some studies that are looking more at the sort of general inflammation type of ones. Um, so yeah, there's very smart people across the country who are just trying to tackle this because it affects everyone in some way, right? You either live long enough, and sometimes it just comes with the territory, right? Your risk goes up and up and up because you're living longer and longer, and so it's like, um,
Normal aging, kind of.
Yeah.
Exactly. And so we're just going to need more answers. Women are continuing to live longer and also just being more productive in like the workforce and out and so I just started recently working in sort of a menopause cognitive clinic at
Mm.
UCLA, and you just kind of see like this very high performing women at the top of their game, right? The kids are out of the house, they can just focus on themselves, their dreams. And then it's like, wait, menopause comes and estrogen is actually neuroprotective. And so it's like, okay, what do we do now? Words aren't coming as quick. I have the information, I'm very intelligent, but I can't retrieve it as easily. And what do I do? So there's just a lot of questions right now, and we're trying to start getting more answers. But it's an exciting time in this space as a clinician and as a researcher, because I do think that we'll be having an even more rich conversation in 10 years.
Women get it all with hormones. But let's answer a few questions because I really don't want to miss the opportunity for the presentation. Lisa, you were given a question. Lisa, thank you so much for sharing. I'm sorry to hear about your husband. Can you share what the subtle symptoms your husband was experiencing when he was 55?
Mm. So subtle, so subtle. This is somebody that, kind of lost, forgot where they put their wallet anyway or their keys. And I didn't know that what it was happening at work. And I think slowly he wasn't able to keep up with work and the demands of it. He was under more pressure. He took a new position and was let go within 3 years. And it's just one day, one time he just walked right into the screen door, just odd things that throw you off. And like any other dementia, I'm an Alzheimer's and dementia placement specialist. So I see everything as a pattern. Um, it comes and goes. And I also work with a lot of families and they're like, well, they're not like that all the time. And it's kind of, but that's the roller coaster ride of the disease and the progression. It's so subtle. And I always say denial protects us too. I don't have anything specific. I mean, but once it started kicking in and the more stress he was under, he'd forget where he parked his car. It was just little things more and more started showing up. And he was in the earlier stages for a long time. But it became, with the frontal temporal, he insisted on driving, and it became more and more. He hung on to that, and he made decisions that were not in his best interest and had no logic to them. Tammy, do you have anything to add to that? Because you are really, sometimes I'm coming from such a place where I'm in the trenches.
Mhm.
You are in a different place and maybe can answer that question better than I
Right.
can.
It's really hard. I think one of the reasons why it's hard to get an early diagnosis is because the symptoms start off so gradual. This is again why I have people document, because the minute you start observing something's off, something's different. The other thing I encourage people is trust your gut. You know, our rational brain wants to not believe, but my gut tells me something's off, and trust your gut. Pursue your gut. If it's even an inkling out of character for your loved one, that can be a red flag. Now, that being said, I'm not going to say every symptom is going to lead to dementia, but it's going to provide, again, some clarity, because one of two things is going to happen. Either it's going to be a fluke and it's not going to reoccur. And if it does reoccur, it's a long time from now, or we're going to gradually see things will start to increase. And it's usually not just one. If there's one going off here, there's often another symptom and another symptom that might be playing out simultaneously. But none of us want to believe that our loved one could be having cognitive impairment. None of us want to believe that our loved one, there's just something off, because what does that mean, right? So here again, if it's a fluke, if it's something out of the ordinary, it's just not normal or usual for them, I say write it down. Let's see how much it's starting to play out. And oh, what other things might be going hand in hand with it, right? Because often, and Dr. Adrissi, correct me if I'm wrong, aren't they symptomatic somewhere between 3 and 8 years before we even sometimes get a formal diagnosis? So you have these early studies where you could participate in possibly a study, but you might not be early enough because the symptoms are so gradual. So this is where I really encourage people that when you think something's just off, that's the time when we start really observing, paying attention. We're not looking for problems. We're observing, documenting, and let's see how it unfolds, right? But that's the hardest things, that I have clients who want to do clinical trials and they're not a candidate, but they could have been a candidate 3 years ago, right? So there's just so much loose ends that once we think something's off, let's just keep an eye on it. That's what I really do recommend. And
And
then
Tammy,
when we're in the thick of it, because I'm in the thick of it with the family caregiver, this is again where documenting and observing, but more importantly, too, I can't tell you how many times I say, well, here's the good news. That is normal behavior for a person with dementia. The bad news is, how do we deal with it? How do we navigate it? How do we manage this? But I think also getting more educated about what to expect will also allow us to be more open to exploring what other possibilities there are.
yeah. And I think if I can pop in, it sort of ties in with with like the first question that we have here. And I want to turn it over to Dr. Adrissi. The question is like, understand the importance of describing the symptoms as the process goes along. Like we've said, like note taking, but how do you say these things when you're in an appointment with your loved one
Yeah.
who they don't realize what they're doing? They're fine. So how do, and again, as a doctor, how do you want to the caregivers to address this with you so that you get the clear information as opposed to what might actually be said? Because there's lots of nuances here that you have to deal with.
No, I think that's an excellent and very just real world question, right? Because it's the person's who's going through the symptoms is dealing with it. And then also the family members are like, how do I navigate this? Especially when there's different types of roles, right? Like that might be your parent, or your spouse, and like they might actually get defensive. So I've seen that where people can actually get quite defensive, even, quite angry. And it's not necessarily them, right? It's some of them processing, some of it's like processing these new symptoms that were not in their, plan, right? And then also some of like the disease itself. So what I usually recommend, one of the great things about a lot of our clinics is that we have the portal, the messaging portal. Oftentimes it's the family members that use the portal more so than the patient themselves. And so using that and actually a lot of times people will send me like messages right before or like a couple of days before the appointment where it's just like, hey, I'm not sure if we're going to have time to cover this, or I might not feel comfortable saying this in front of my loved one, but I want to make sure that this is written down somewhere. Like it's helpful to be succinct as possible, I will say, just to make sure that it gets read. And things that are important to add in those types of messages are sort of the most important or like the most bothersome symptoms or things that you've seen kind of ranked, right? Because sometimes somebody sends me a 2-page thing, and the most important thing is at the end, like, oh yeah, and they, wandered and left the house and we had to call 911. It's all the way at the bottom, and I might not get to it before the meeting. And so just kind of ranking like these are the things that have been going on in this timeline. Want to make sure that this is addressed. And so what I'll usually do, I won't like especially if in there they're kind of, don't want to embarrass their family member, etc. I'll just ask about things like, sometimes people get lost. Sometimes these things happen. Is that something that's happened to you? Or if this does happen to you, these are some of the tactics or these are some of the things that we would do. And so there's a way to kind of tactfully do it, but also make sure that the clinician has all of the information there. And to echo what Tammy said before, it's always fine to just bring up something if you have an inkling that something's off, right? Whether it's initially to your primary care doctor, et cetera, like something's off, this happened, whether it's me personally or my loved one, I'm concerned about it because sometimes it's just different from their baseline, right? So some people have, who knows how many degrees and they're functioning here. And like, yes, they're still probably in the 90 something percentile, but they were functioning at 150. And so it's really like the pace of this decline. Some things that can be helpful, even when we're not totally sure early on, is just baseline testing. So that can be something as simple as, an in-office screen, which is a little bit less sensitive, like a MoCA. There's also neuropsychological testing, which is like a 3 to 4 hour more extensive testing that breaks down the different domains of cognition and kind of pull out different deficits, even when they're more minor. So that can be helpful just to really kind of put language around like this feeling that something's off.
Mhm. So, Dr. Adrissi, just realizing too, the good and the bad of these presentations is we get into great conversations and we have these great dialogues, but we also realize we have 8 minutes left.
I know.
I also I want to make sure that with whether it's your official presentation or not, but I because we brought you in here as the expert on Parkinson's disease, Lewy body, and also just lots of your the other research that you do, talking about disparities and stuff. So I was wanting to sort of turn over the last few minutes that we have to you to address those. We see that there are some questions in the chat. We will either answer them in directly in the chat, or we'll follow up with you afterwards. So just wanting to sort of give Dr. Adrissi the time to focus on this specific part. So I'm going to be quiet, and it is all you now.
All right, let me try to maximize this. And hopefully I'll answer some of the questions that were there within the context of the presentation. It's a short one because I really did want this to be mostly a conversation. But this might be helpful for our more visual learners like myself. And so that's me, Jennifer Adrissi. I'm at UCLA. I work in the movement disorders division and do a little bit with Easton Center as well, which is our more cognition and dementia center. All right, so the Parkinson's Core Collaborative. And so when I got to UCLA about 2.5 years ago now, I came from Northwestern in Chicago. I do a lot of community partnered work. Community partnered work really to try to solve complex problems of access to specialized care as well as clinical trials. Particularly in Black and Brown communities, but really just in general, getting the information out there about Parkinson's disease and other neurodegenerative disorders, do some about kind of dementia in general, We are based on four main pillars, which is community building, outreach, research, and education. So we do a lot of tabling. We do workshops at community centers, really bringing the information and the resources to the community and not really expecting people to come to us in Westwood, which can be really hard, and LA traffic and all of the things. So that's just in general. If you want to talk offline about that, we can talk more, but I'm just going to keep it pushing for the sake of time. So this umbrella analogy, Monica really set the stage for already, and there's a ton more other things under this umbrella of dementia. Lewy body dementia or dementia with Lewy bodies being just one of them. So it's a spectrum, which we already started talking about, this Parkinson's disease dementia, and then the dementia with Lewy bodies. And it's really that time course that we talked about. Is the cognition, the cognitive issues the first thing that happens, or is it within that first year of the motor symptoms, or is it later on? If it's later on, then we're thinking more of that Parkinson's disease with dementia, caused by that abnormal protein called alpha-synuclein, and affects over 1 million people in the US alone, and that's just the Lewy body dementia. And so we talked about this already, really sort of the different distinguishing factors. Sometimes it gets a little blurry because our brain and our bodies do not read the textbook. And that's okay. If you're like, well, was it exactly at 1 year? Was it at 9 months? I'm not sure. A lot of the management is similar, right? Whereas some of those definitions become even more important is when it comes to research studies and qualifications there. Key features of Lewy body dementia. So I really think of Lewy body, it's an overlap, right? It's an overlap of a lot of your Parkinson's symptoms and then some of the similar symptoms to Alzheimer's disease. There's some that are distinct, but just really think about it as sort of that, we call like a Venn diagram where those two circles overlap and in the middle is Lewy body, Parkinson's and Alzheimer's. It's an easier way to think about it. Not necessarily that simple as far as the molecular part of it, but it's an easier kind of concept. So you have cognitive symptoms, difficulty with memory, processing, some sleep disturbances. So someone said, what are some of the very early things? So one of the specific things about Lewy body dementia as well as Parkinson's disease is REM behavior disorder. So REM behavior disorder is sort of acting out of dreams, people kind of kicking and kind of moving around, sometimes they'll shout and they're really acting out their dreams when they're actually asleep. And so that's something that is tied very closely to Lewy body as well as Parkinson's disease. So a lot of our research right now is actually identifying people with REM behavior disorder, because somewhere between, depends what study you're looking at, but somewhere between like 70 and 80% of people with this REM behavior disorder will eventually get some type of alpha-synuclein disorder, whether it's Parkinson's disease, Lewy body dementia, and there's something else called multiple system atrophy, which all have that alpha-synuclein. So movement and motor symptoms. So think some of the Parkinson's-like symptoms, right? So stiffness, more so on one side of the body than the other, slowness, sometimes people have the tremor issues, walking issues, balance issues. And one of the limitations in Lewy body is that one of the medications that we use the most, which is carbidopa levodopa, it sounds like a witch's potion, right? But it's not. It's two medications in one pill, that levodopa part being the dopamine providing part. Dopamine is low in Lewy body as well as in Parkinson's disease. And so we try to give the body back dopamine in the form of levodopa. Levodopa for people with cognitive and thinking issues or even confusion in Lewy body or Parkinson's disease with dementia, it can cause people to be more confused. It can cause more hallucinations. So you're kind of stuck between a rock and a hard place. So what we do is go really slowly with increasing the medications for the motor and movement symptoms as high as we can without, significantly worsening the cognition. And then behavioral things. So some people kind of lose that filter, right? That the filter that's like, I'm just gonna jump out of bed, although, my balance is off, but I'm gonna get up by myself and that's fine. And so it's sort of that can be affected. People can be a little bit, it really depends. So some people, they don't notice a ton of behavioral changes. Some people have more personality changes, a little bit more with frontotemporal dementia and Alzheimer's, but you can get that in Lewy body as well. We talked about RBD, or that REM behavior disorders. There's memory issues, balance issues, the slowness and stiffness, which is in Parkinson's, it's usually much more on one side of the body than the other, but affects both sides. And Lewy body dementia, which is one of the kind of atypical Parkinsonism, it's another type of umbrella. It can sometimes be more symmetric. You can have tremors, but you can also not have tremors. And so the absence of tremor doesn't mean that someone doesn't have Lewy body. Difficulty focusing, and we talked about those hallucinations. Causes and risk factors, we talked about that overlap of genetics and environment. Usually people are over the age of 50, usually kind of 60s or so, but definitely over 50 for the most part when you're thinking Lewy body dementia. Diagnosis, we talked about the fact that it's a clinical diagnosis, that timing is really important. And then who manages people with Lewy body dementia? So there's an overlap. So I'm a movement disorders neurologist, which means that I had 4 years of adult neurology residency and then followed by 2 years of movement disorder. So I see Parkinson's, other kind of cousins of Parkinson's, if you will, like Lewy body. You also have your cognitive behavioral neurologists who are also trained and have your neurology residency, but then they go through a cognitive behavioral fellowship, which includes like the Alzheimer's disease, the Lewy body. So there's an overlap in people who may treat Lewy body. Misdiagnosis and underdiagnosis is very common. And we talked about some of the different modalities that we'll use to help with the diagnosis. There are a lot of different categories of treatment, right? I always say treatment is not just medicine. And oftentimes in Lewy body, because of side effects of treatments, a lot of the management ends up not being medicine, right? It ends up being all the other support types of structures. There are no Lewy body medications only type of category. We use medications that are from the Parkinson's disease side of things to help with the movement type of symptoms. And then we borrow some from the Alzheimer's disease medications as well. Physical and occupational therapy become really helpful, especially for some of the physical symptoms. Occupational therapists are trained sort of in two main additional areas. One is they do a lot of fine motor movements, and then also really help you manage your symptoms in the context of living day to day as well as work. Speech therapists help not only with speech, but also sometimes with cognition and some cognitive therapy. So that can be helpful. Music therapy can be helpful. Exercise is very valuable. It helps the body, but also the mind and sort of the mental. Schedules are very helpful. And so some people say, like, what are things that I can do tomorrow for my family member? And one thing is like to put together a schedule, especially if they're retired or they're at home. Sometimes they can be like in front of the TV or just sitting or just in bed, right? And so if you're saying, at Mondays at 9 a.m., we are going to a chair aerobics class. At this time, we're doing some music, and sort of adding more structure to the day is actually very helpful cognitively for patients or people living with Lewy body. Exercise, nutrition, medications, and then just keeping them engaged, right? It may sometimes be a little bit more difficult, but keeping the conversations going, the phone calls with friends, having people over as much as possible to decrease that isolation is very helpful. Also, screening for mood type of symptoms, because, two things can be true. People can be going through dementia, but they can also have mood issues like depression and anxiety. It does become more complex to treat some of those mood symptoms, but very much important to screen for them. And then I think someone I'm forgetting mentioned earlier, some of like the confusion types of symptoms, they do become more complex to treat sometimes with people with Lewy body, because oftentimes those medications block dopamine and the dopamine is already low. So in trying to improve someone's thinking, they might actually make them very stiff and sometimes even worsen confusion. There's just a few resources for Lewy body. There's Lewy Body Dementia Association. They actually have a link there for a lot of the ongoing studies. I did see one of the questions in the chat about that. There's the LA Found program, Alzheimer's LA, as well as Parkinson's LA. They know that there's an overlap of symptoms between Parkinson's disease and Alzheimer's, and oftentimes you can benefit from from both of those resources. So that's that. I also saw a question in the chat about an MRI being normal in dementia, and that is actually very common. And so you have to lose a lot of brain cells for us to start seeing it on like the big level on an MRI. And so just because an MRI is normal does not mean that someone doesn't have dementia. Oftentimes it is normal, especially early on. All right, so I do have actually a back-to-back presentation, so I'm gonna have to hop off in a little bit, but is there any kind of main follow-up of questions? Thank you for having me. This has been amazing.
Thank you so much. And we do have a couple questions specific to Lewy body in the Q&A, three of them, which is is there medication for hallucination? And you talked about mood and depression. Is there a higher and suicide rate, which I'm sure people were thinking of, our hysterical actor Robin Williams, um, and is there any link to military bases with a higher Parkinson's diagnosis?
Yes, so there's lots of different environmental factors, one being Agent Orange, which is exposed to some of our veterans. And so Parkinson's disease actually qualifies as kind of one of the diagnoses that gets benefits with the military. So yes, so that connection is there. Just biologically, people with Parkinson's disease and Lewy body dementia are more at risk for mood disorders. And so that's just, abnormal, chemical balances, because it's not just the dopamine that's affected. Serotonin in the brain is also affected in both of these disorders.
I can't thank everyone enough. And we'll get back to the question about ADD and association with dementia, because I'm actually most interested in that. But I can't thank everyone enough. And please join us on July 2nd for part 2. Feel more than free in your registration to ask questions, and we'll get right to those as soon as we can. But what a wonderful roundtable conversation. We achieved our goal. I can't thank Dr. Adrissi. You're so busy, and that you came with us, and I just love what you do for the community at whole. And thank you, Monica, Tammy, and Lisa. And we'll see you July 2nd. Thank you.
Thanks for having me. Bye,
Thank you.
everyone.
Be safe.